Thank you for joining us for the third webinar in the series presented by the Association for Pathology Informatics and SunQuest Information Systems. My name is Kristen, and I will be your moderator. Today's webinar is presented by Dr. Bruce Levy, Director of Informatics and Associate Professor of Pathology at the University of Illinois at Chicago. This webinar will be recorded and available on API's and SunQuest's corporate website in the next 2 weeks. Attendees will remain on mute for the duration of the webinar. If you have any questions, please type them into the questions field on your control panel, and Dr. Levy will answer them at the end of his presentation. Thank you so much, and Dr. Levy, I'll pass it on to you.
Okay, thank you, Kristen. Good morning or good afternoon to all of you, depending on where you're located. I'm here to talk about whether we can resurrect the autopsy in the high-tech IT world of today. Back in 1998, George Lundberg wrote an editorial in JAMA titled Low-Tech Autopsies in the Era of High-Tech Medicine, in which he said the autopsy is not dead, but it slumbers deeply, apparently the victim of a vast cultural delusion of denial. He went on to say, in fact, there is still a giant gap between what high-tech diagnostic medicine can do in theory, in ideal circumstances, and what high-tech diagnostic medicine does do in practice in real-life circumstances. It is now 15 years later, and what's interesting to me is the more things change, the more they have really stayed the same. So the question we have today is it time for high-tech autopsies in the era of high-tech medicine? An autopsy basically comes from the root meaning to see with one's own eyes, but an autopsy is an examination of a body for three purposes: to determine the cause of death, document the extent of disease, and document the extent of injury in the body. And this is common to all autopsies, whether in the forensic world or in the medical world. Today we're going to mostly focus in the medical world, though we're going to see how the forensic world can help us out. Things that are specific to the medical autopsy is typically we're here to answer questions of the clinical team regarding the patient, the care of the patient, the diseases the patient did or did not have. We're providing information to the families about the cause of death, as well as identifying any risks that the family needs to be aware of for their own health. Frequently, we're identifying disease that had not been previously diagnosed or even suspected by the clinical team, as well as investigating complications of new treatments or procedures, as well as any complications that may have been suspected of procedures that have been around for quite some time. Many of you probably recognize this painting of a 15th century post-mortem examination. And here in the equivalent is the 21st century post-mortem examination. And while on the surface there appears to be a lot of differences, the real question here is, has anything really changed in the last 6 centuries? And the answer to that question is, while some things have changed, the basics of what we're doing really have not changed much. And so is this the future of the autopsy? I'd like to now spend a few minutes and talk about the decreasing or changes in autopsy rates that we're seeing in our hospitals throughout not just the United States but around the world. And if we look at the data over time, you could see back in 1910, at the time of the Flexner report, the autopsy rate in U.S. hospitals was approximately 10%. And as a result of many changes, mostly as a result of the Flexner report, we saw a huge increase in the autopsy rate, which approached on average 50%, and in many places much in excess of 50% around the middle of the last century. This began to drop off as we moved into the second half of the 20th century. In 1971 was the end of the requirement for a minimum 20% autopsy rate for hospital accreditation. And you can see how the number since that time has continued to decline till in 2010 we're looking at about, again, a 10% autopsy rate for deaths in American hospitals. In some places it could be significantly lower than that. In some of the academic medical centers, significantly higher, still in the 20 to 30% range. But the interesting thing here is we have really come full circle in terms of autopsy rate in the past century. And that really raises the question of whether the autopsy is still relevant in the 21st century. Some of the reasons we've seen the decreasing autopsy rate. First is what we just discussed about there's no longer any requirement for autopsies to be done in order for hospitals to be accredited. Clinicians have greater diagnostic confidence, mostly as a result of many of the high-tech tools that are now present, a lot of them radiologic, but many other tools as well. There's a general belief that finding out things at the autopsy will risk the increase in malpractice and result in additional malpractice suits. We're going to take a look at that in a few minutes. One big issue is the ever-increasing workload of pathologists. There's greater difficulties in getting consent from the next of kin, though given the popularity of a lot of the forensic shows on television and general public interest in the area, in many cases it may actually be difficulties with our asking properly for the consent rather than the lack of consent itself. And finally, like in many things, a lot of this revolves around money and the lack of money and financial support for autopsies. Looking at the topic of greater diagnostic confidence, basically it's been shown time and time again in study after study that autopsies, even today, continue to uncover substantial discrepancies between autopsy findings and known clinical diagnoses at the time of death, and that these differences have not changed. They have not been eliminated, and they persist to this day. In a 2003 review article in JAMA, they looked at 53 prior autopsy series that evaluated autopsies related to diagnostic errors, and they looked for both major and minor diagnostic errors. One of the challenges they had in doing this study and many other studies like it is that the definitions of what major and minor diagnostic errors are is not uniform. So in some cases, these articles have trouble correlating one study from another. But this study happened to demonstrate that the rate of error had shown a significant decrease decade over decade. So there has been improvement. But they estimated that in the year of the article's publication, that the rate of major errors was still somewhere between 8.4 and 24.4%. And just to put that in perspective, in that year there were about 850,000 deaths in U.S. hospitals that year. So looking at the 8.4% rate of major errors, that represents 71,000 deaths. And the data further suggested that approximately half of those deaths may have been unnecessary, and the patients might have survived to discharge had that diagnosis been detected during life. That represents nearly 35,000 deaths. Several years later, an article in Critical Care compared Again, diagnosis, pre-mortem, and autopsy findings, this focusing on patients in a tertiary care cancer center in the ICU over a 6-year period, with an autopsy rate, in this case, of 13% of those deaths. And they found a discrepancy rate of 26% and concluded more than half of those impacted the survival. The most common missed major diagnoses in this series were opportunistic infections and cardiac complications. And this is a significant rate, much higher than the rate suggested in the previous article. So you can see, as a result of these and other studies, which I'm not citing because of lack of time, that the issue of autopsy remaining as the gold standard for for diagnosis still remains, and autopsies are still necessary in order to fully evaluate patients and their causes of death. The next topic I'd like to touch on is the issue of whether autopsies do or do not lead to lawsuits. The CAP Autopsy Committee studied this issue back in 2002, and I've listed here a couple of quotes from this story which we're going to go through. And you can see that findings of medical negligence is not based on whether or not the doctor actually got the right diagnosis, but is really based on standard of care issues. That autopsy findings are typically not the crux of the issue involved in malpractice cases. That this, again, goes back to standard of care questions. And that the fear of autopsy findings really had no rational basis and represents an important obstacle to what they called uninhibited outcomes analysis, which is really the evaluation of deaths in hospitals and why they are happening. What was interesting in this study was in cases where they evaluated the autopsy and felt that it favored the defense in this case, all cases did find for the defense, meaning the physicians. But in cases where autopsy favored the plaintiff, 61% of the cases still found for the defense. So, as you can see, autopsy findings really are not a very critical part of lawsuits and the reasons for them. What was interesting is they had a second part to their study, and they looked at issues where in malpractice cases the autopsies became part of the controversy. And the issues were really over the quality of the autopsy, delays in autopsy reports, inconsistencies within the autopsy report, omissions in the autopsy report, and discrepancies between the autopsy report and the death certificate. And as you'll see as we go through this talk, many of these issues are common problems that we're facing that are recognized within the legal community, within the medical community, and among families. A more recent study in anesthesiology, anesthesiologists looked, they keep a record of all the claims against anesthesiologists and looked at closed claims for death. After 1990, there were 980 such cases. And what they found among the cases, 551 cases where there was an autopsy, so about 56% of these closed claims had autopsies. Autopsies helped the defense more than half the time and helped the plaintiffs about a quarter of the time. And when you look at the literature, the bottom line as to why there are lawsuits really revolves around the issue of poor communication between healthcare providers and families. When families feel they're not getting answers, when their questions are not being fully answered, that pushes them to file lawsuits. And time again, you hear of cases where families say they filed lawsuits because they just wanted answers. And obviously, autopsies are a great way to resolve this issue, to get answers to families and provide them the answers to the questions that, one, they deserve, and two, that will help avoid lawsuits. Now, clearly, the increased workload of pathologists is a huge problem, and we all know that the volume and complexity of surgical pathology cases is increasing and will continue to increase, that the demands in the clinical pathology area demand more and more of our time, that autopsies do take a significant amount of time, they do not generate revenue, and interestingly, pathologists perceive that autopsies are not appreciated by the clinical staff. And we'll see later on that this is not really true, but there are issues involved as to why there is this belief among pathologists. Next of kin frequently will not be interested in consenting for autopsies. Obviously, families are traumatized by these deaths, even when they have been expected. There's frequently a belief that the deceased has, quote-unquote, suffered enough, and there are mistaken beliefs that the autopsy will either delay the funeral or prevent open casket viewing, neither of which is true, and we're not doing a very good job at communicating this to families. In some cases, there are also trust issues where the families are not trusting of the pathologists to actually perform an objective autopsy, especially when the pathologists are within the same institution as where the death occurred. And this is an issue that can also be addressed. So the question is, what do? We can either pull the covers over our heads and let the autopsy go, or we can take the bull by the horns and move towards a renaissance of the autopsy. And obviously I'm here to talk about the latter. So the first step to talk about is the virtual autopsy. So what is a virtual autopsy? It's a non-destructive examination of the body using modern radiologic techniques such as CT or MRI scanning. And virtual autopsy really got its start, and most of the work to date has been done within the world of forensic pathology. And there have been two basic directions where this is developed with two different philosophies. One is really exemplified by the Autopsy project, which is involving non or minimally invasive autopsies. And the other is the work started by the U.S. Department of Defense, the Armed Forces ME, in the use of CT scanning as an adjunct rather than a replacement to autopsy. So the Autopsy project comes out of Bern, Switzerland, the Institute of Forensic Medicine. And by the way, for those of you who like using the term Autopsy, they have actually registered that as a trademark, so you need to give them credit whenever you do use the term Autopsy. And it is basically the use of these high-tech tools in daily forensic practice, which involves 3D mapping of the outside of the body, multi-slice CT scanning, and MRI scanning. For the Armed Forces Medical Examiner, this all started with their need to autopsy all of the soldiers who had fallen in battle, but they needed to identify unexploded ordnance before going in and performing the examination. And what they found very quickly was they were discovering information that could be used to basically help the survivability of our fighting force. They learned a huge amount of information, most of which we're unfortunately not privy to. But it has helped in the development of techniques to increase the survivability of our soldiers. For example, there was a 2007 report that they had been recommending 5-centimeter catheters for decompression of pneumothoraces in the chest, but they found from their CT of military personnel who had fallen that the average chest wall thickness in military personnel was 5.36 centimeters. So this led them to recommend an increase in the length of these catheters, improving treatment for soldiers in the battlefield. So the capabilities of this virtual autopsy, the advantage of 3D surface scanning primarily is involved in the forensic world and really involved with documenting and comparing injuries and the alleged implements that cause those injuries. What they found is that the CT scanners are best for evaluating skeletal injury or skeletal disease, while MRI is best in the evaluation of soft tissues. So both these techniques are needed. So what they're able to do in the forensic world through virtual autopsy, in a lot of ways better than we could do with an actual autopsy, is 3D pattern reconstruction of skeletal injuries, and especially injuries in areas of the body that might require difficult or disfiguring dissection, such as facial injuries. Virtual autopsy is also superior to two-dimensional X-rays in terms of localization of foreign bodies, primarily ballistics within the body. It's also very good at distinguishing the different density of objects, although a lot of the fluoroscopic scanners that are now available in forensic offices can very easily distinguish bone from tooth, from metallic core of a bullet and the copper jacket of a bullet through the different densities. Virtual autopsy is also quite superior in the detection of gas contained within the body, such as pneumothoraces or air emboli. These would typically involve very specific techniques by the pathologist performing the autopsy, and if it's not done correctly, can easily be missed. In these cases, virtual autopsy can very easily detect and diagnose this. Virtual autopsy has also begun to show some promise in looking at the estimation of post-mortem interval, basically examining the relative concentrations of different amino acids within the brain and how they change as the post-mortem interval increases. And the other main advantage of the virtual autopsy is basically that it is non-destructive, that you can actually examine the body and not actually destroy anything, as opposed to a typical autopsy where your best look is at the time of the autopsy, and trying to go back and look a second time is problematic at best. Some of the disadvantages of the virtual autopsy is that, one, what they've learned is you need both CT and MRI scans, and that is obviously expensive and time-consuming. And they are currently looking at options such as creating parallel imaging devices that can both do CT and MRI scanning at the same time, or a faster MR process, because basically the time-limiting step here is the time for MRI. The second disadvantage are artifacts, both those generated by metallic objects, which can create scatter to the image surrounding it, as well as artifacts of post-mortem change, which can be mistaken for actual findings. Both these things are not really a whole lot different than the artifacts that we've learned to deal with in the forensic world. And really the answer to that is going to be time and experience in people learning how to differentiate artifact using virtual autopsy from injury and disease, just as we have done in the pathology world. The next disadvantage of virtual autopsy has been the evaluation of vascular injury and disease. Neither CT or MRI have been totally effective in evaluating things like coronary artery disease or aortic dissections and things of that nature. And they've actually begun to address that issue by using techniques such as postmortem angiography, which is a minimally invasive procedure that we'll talk about in a moment. The other main disadvantage is you cannot show pathologic changes on a microscopic scale, and basically what they are now developing is guided biopsies based on CT and MRI scanning. So for postmortem angiography, they're now using modified heart-lung machines to inject contrast into the vascular system. When it does work, you can get an excellent view of the circulatory system, which in some ways is even beyond that of the typical autopsy. And it is a minimally invasive procedure. Some of the downsides that they've learned is that this can in fact even be an artifact-producing procedure. There's a paper earlier this year giving an example of an artifact causing pericardial effusion through the use of postmortem angiography. The other side is dealing with histology by doing CT-guided biopsies, where basically scanning the body identifies the lesion of interest, which would then direct a human or a robotic-guided biopsy to get that lesion and submit it for histology. This is also a minimally invasive procedure. So the Virtopsy people are suggesting, if you go to their website, what they're referring to is the Virtobot, or maybe we could call it a robotic pathologist, which is a robotic system that basically scans the body, gets 3D reconstruction of the surface, and performs CT-guided postmortem tissue sampling. So one can only imagine what Dr. Virchow might think of this as this technology gets developed. So the question now is, this virtual autopsy work has really been performed almost exclusively in the forensic world. Could we apply these principles, either whole or in part, to the hospital autopsy? And if we could, this would certainly address the issue regarding invasiveness of autopsies that make people squeamish about the autopsy. And really, if we think about it, this gets its start with radiology autopsy correlations. And there are many places which are performing postmortem CT or MRI scans as a precursor to the autopsy. And the huge advantage to this is it's providing pathologists with basically a preview that allows the pathologist to focus their examination on areas that are of specific interest. One, both clinically identified, and now two, identified through radiologic technique. And more importantly, it allows for correlation between radiology findings, gross and microscopic findings, and not only that, but comparing antemortem and postmortem radiology as well. This is from a 2003 paper giving an example of how this technique might be applied. You can see here in image A, a T1 weighted image of the abdomen, in 2, a T2 weighted image showing a lesion within the liver. Now an MRI focusing in at the organ level, and then comparing it to the gross specimen in D. And you can see how this makes a very nice systematic combined picture of how we can evaluate disease, in this case hepatocellular carcinoma. So there is a study from 2009 in radiology where they had 30 hospital patients who had passed away who underwent a minimally invasive autopsy followed by a complete autopsy. The minimally invasive autopsy was a combination of CT and MRI and ultrasound-guided needle biopsies of the major organ systems as well as any lesions identified as of interest in the previous scans. And what they found in this study is they had a 77% agreement on cause of death, which is clearly not acceptable, but is not a horrendous number. And their main difficulties were with cardiac disease. They also experienced a 3.3% failure rate in actually obtaining biopsy tissues. Most of their cardiac disease failures involved acute myocardial infarctions, coronary artery disease, and endocarditis, and obviously the first two representing one of the major causes of death, the major cause of death in the United States at this time, represents a significant shortcoming of this technology. The one thing that they did recognize was that you really needed to use all three of these modalities in order to maximize your ability to detect disease by minimally invasive autopsies. This is something you can't just accomplish with CT or MRI alone. You need all three of these techniques in order to maximize the yield, which at this point is still not acceptable for clinical care. So the next thing to look at is what I call scopic autopsies, which is another minimally invasive option. So in this case, you're using laparoscopes and other scopic tools to perform minimally invasive postmortem examinations. The advantages here are you're getting direct visualization through the scope of the internal structures. You're actually seeing it with your eyes rather than relying on radiologic scans of these areas. And you can obtain much larger biopsies, which you're also getting through direct visualization. The main disadvantages of this technique is that it is quite limited in the extent of the examination. When I first started working in the National Medical Examiner's Office in the late 1990s, I partnered with Vanderbilt University where we did attempt some laparoscopic autopsies in a few instances. We never did publish the work that we did. We had fewer than 6 cases where we had performed a laparoscopic autopsy. But we did see some of the potential advantages of this. Fortunately, there have been some other work performed in this area, and this is a 2010 paper where they took 22 cases where they performed laparoscopic and thoracoscopic examination. 2, they also did arterioscopic examination in addition. And they did much better than virtual autopsy. They obtained a diagnostic accuracy comparing to a complete autopsy following the scopic autopsy of almost 95%. The main problem here being the negative predictive value, which you can see here is 89%. So, the lack of being able to see everything still remains to be a problem. The other thing that I found really significant about this study was the duration to perform these procedures in the median was 78.3 minutes. So in terms of time, it definitely favorably compared to the duration of performing an actual autopsy. So we were not looking at a procedure that would take excessive amount of time to perform. And these are a couple of pictures from that paper where you can see a biopsy being taken here of necrotic pancreas, and in this case, an arterioscopic examination of an aortic dissection showing the false lumen. And you can see the visualization here is really quite good, and you are able to get more than adequate specimens. The advantage of these virtual techniques and these minimally invasive autopsies primarily really help to address issues where families may be reluctant or refusing to agree to a full examination. So the ability of having alternative tools at our disposal to perform these sorts of examinations are going to be very helpful in improving how we can raise autopsy rates by providing options to families. We also need to take a look at some of our traditional pathology tools and how we conduct the autopsy. The first being histology. In a 2005 paper looking at discrepancies between clinical diagnoses and autopsies, they estimated that over 20% of unexpected findings at autopsy were only diagnosed using histologic examination, so they were not grossly obvious. This is an important thing to remember, that histology remains an important component of the autopsy and should not be excluded. Now, if we look at the use of histology with autopsies, we find that histology is routinely taken in autopsies in academic institutions, but they tend to be formulaic and not always goal-directed. So there's a list of specimens that need to be taken, and unfortunately there's not always really good thought directed as to how that's going to be done. In non-academic hospitals and in forensic cases, histology is much less likely to be utilized, and when taken is quite limited. I've always been amazed by the number of forensic offices that will tell you that they do histology in all their autopsies, where histology is really one block where they have stuck 4 or 5 pieces of various organs into a single block. And obviously that is not a sufficient examination if you're going to be performing histology. Now, the flip side of that argument is obviously, we're living in a world of limited resources, and do we need to be examining everything all the time? And my argument would be we need to be intelligent about how we use histology. The other thing about histology is it's mostly limited to H&E stains, which much more infrequent use of any special chemical stains, immunohistochemistry, and some of the other histologic tools that are coming online, such as FISH and immunofluorescence. And the question I throw out here is, shouldn't we be able to compare a tumor in a patient during life with the tumor after death? And that will be invaluable in our ability to evaluate the effectiveness of treatment and how this tumor may have changed as a result of treatment. The problem here, again, is these decisions are driven by cost. So, it goes back to the theme of needing to lobby for additional resources for autopsy. Very few places are doing microbiologic cultures related to the autopsy. And what's interesting here is the common belief is that postmortem cultures are not valuable. And the 3 things that we commonly think of as why these cultures are not useful is agonal spread, which is the spread of bacteria during the dying process, postmortem translocation of bacteria that are already existing within the body, and then contamination. The reality here is that careful attention to obtaining specimens using sterile techniques is really the key in getting specimens that can be very useful. Back when I was a resident at the University of Massachusetts, a hospital we rotated at performed blood cultures routinely on every autopsy. It was always obtained by the same autopsy assistant who worked on the autopsies. He followed basically the same technique each and every time. And when you looked at the data, you found that the data was actually useful and meaningful. because the procedure was done in a consistent way with an eye towards maintaining as near as possible a sterile technique. This was also supported in a 2006 paper in Journal of Clinical Pathology, which was a review of articles of postmortem bacteriology involving 5,000 cases, nearly 5,000 blood cultures, 1,100 CSF cultures as well. 2/3 of blood cultures tend to be negative. 2 out of 9 yield a single isolate, and 1 out of 9 have mixed growth. They found postmortem interval in reviewing these series has a very small impact on these results, and that the major artifact is contamination when obtaining the specimen rather than agonal spread or translocation of the microorganisms through the deceased body. And what they concluded is the concept that the entry of several bacterial species at the time of death being inevitable is not correct. This does not happen. And that a pure growth of a pathogen or blood in blood or CSF should be regarded as a contributing factor to death, regardless of the age of the patient. So this is a technique we should and could easily be using. Which now brings us to the autopsy report. Our autopsy reports really haven't changed a whole lot, and they're really not geared to producing information to clinicians and families the way it needs to be done. We're not structuring these information appropriately, and we give relatively low priority to completing autopsies and their reports with unacceptably long lag times between the examination and the final report. The 1999 Q-Probe study showed that over half of autopsy reports were not used for any interdepartmental activities, which is just appalling. A 2012 survey of physicians showed several things, 3 points I found very relevant. 1, response times for autopsies are too long. No surprise. Opportunities for learning from these CPCs are not being done as much as it could be. Again, not a big surprise. And really the bottom line that better communication and quicker response will help increase the rate of autopsies, meaning if we produce a better product, then clinicians are going to be more likely to request them. So the University of Arkansas reviewed 125 autopsies. In those 125 autopsies, the clinicians had asked 103 questions. And this is an important part of the autopsy. Less than 80% of these questions were answered in the FAD. Almost 10% of these questions were answered in the report somewhere, but not in the FAD. Think of how busy clinicians are today. They're not going to take the time to read through a 3, 4, 5-page autopsy report looking for the answers to the questions they had. We need to prominently be providing those answers where they can just look at them and see them. Even worse, 10% were never mentioned at all. And these are some of the examples of things that clinicians asked that were not answered one way or another or addressed in any way in the autopsy report. And we wonder why our clinicians aren't really excited about getting autopsies if we're not answering the questions or telling them in the few cases that this does happen that we can't answer your question because obviously we can't answer all questions. So as if we saw previously, if up to 25% of autopsies have significant findings that were not clinically known, how do we make sure this information is properly distributed, analyzed, and discussed? And the first step is with us, a timely, well-organized, and thorough autopsy report. Seattle Children's Hospital and Pathology at U of Washington actually applied the Toyota production system to the generation of autopsy reports. They identified 77 individual steps involved between performing the autopsy and generating an autopsy report. And through applying lean techniques, was able to reduce those number of steps by 8%. And it was at the same time decrease their mean completion time by more than half, from 53 days to 25 days. And I would argue we should and could do better than this. They identified a huge list of reasons, as you see here, for the reasons that autopsy reports are delayed. The one I really want to focus on are these queues, where we're just waiting for stuff to happen. The clinicians liked the results of this lean process. 70% thought the autopsy reports were better. 85% said we got them faster. All of them said it addressed our clinical issues. 23% said, hey, there's unexpected information here. Again, paralleling the information that we already know. Nobody found these reports confusing. All of them believed it helped them in counseling the family, another big plus for increasing the autopsy rate. Over 90% were satisfied with the level of communication. The ones that weren't were recommending that, hey, give me an alert to check my EHR for this report when it's ready, because I won't always know if it's there or not. Something we could very easily deal with. So the key areas of an autopsy report are the cause of death, the FAD, and the CPC. And we need to focus our attention on these sections and make them relevant and problem-oriented to make them easy for the clinicians to review. And so we basically need to highlight these four things: the cause of death, a problem-oriented FAD, a clear and concise CPC, and especially the answers to the clinician's questions. The other thing we need to look at is structuring autopsy reports. We need to have autopsy reports that are more than just a text dump or a PDF file. We need to structure relevant data to facilitate searching, analyzing, and researching. So I'm not recommending eliminating the report. We can still have a PDF autopsy report within the case file, but we need to structure the cause of death, the FAD, the lab results, using structuring systems we already have in place, such as SNOMED and ICD. We should be including relevant images. We should be including gross, microscopic, and radiologic images, which not only help documentation, but assist with education and communication. Here's an example from a 2004 paper in Archives. And you can imagine how providing these pictures, especially annotated as we see here, along with the autopsy report, goes a long way to help clinicians and families understand exactly what happened in these cases. The last thing I want to touch about in the few minutes we have left is a bit of old-fashioned communication. So just because it's modern does not mean we need to give up on stuff that just works. We've seen that families want the healthcare teams to communicate with them, and they're interested in answers. And we need to sell the autopsy as the procedure that will answer their questions and communicate with clinicians and families. So here's a paper from Family Practice where they interviewed family members months after the autopsy. And what they learned is families basically had three main questions they were looking at. Is there something the family overlooked? How could this have happened to my loved one? And are there any hereditary factors which have consequences for me and the rest of my family? And they also found the best way to explain the autopsy is to compare it to an operation and consider it a surgical procedure. At the University of Colorado, and there are other places that do this, but I'd heard an excellent talk by Dr. Lowe earlier this year, and he has graciously agreed to share the next several slides with us, where he presented to us their Office of Decedent Affairs. And this office is notified of every death. They meet with family members to help them in the initial process. They give them a huge amount of information to help them. They assist them in choosing a funeral home. And finally, and most importantly for us, is they talk about the autopsy and frequently encourage the families to obtain an autopsy. Now, the autopsy rate at the University of Colorado is between 30 and 40%, much higher than most of the rest of the country. This is probably one of the main reasons. Here's just an example of some of the information that they provide to the family. You can see that it is fairly comprehensive. Here's the part where they talk about the autopsy, and you can see that an autopsy is a visual and surgical examination of the body, and they emphasize that the autopsy will not prevent or complicate a funeral or viewing of the body. They make this clear to the families so that they know that they can have an autopsy and still do with their loved one whatever they choose to do. The other thing that the pathologists do is they prepare a letter to every next of kin where an autopsy has been done, explaining to them what the autopsy revealed and helping to explain the patient's disease and death. They do get this passed through the clinician, so the clinician is aware of this beforehand, and the autopsy service chief reviews these letters. They're all drafted and written by the residents. They avoid negative comments about the clinical care, so they're not there to say, "Oop, they screwed up." They're there just to say what was found. And many families are very interested in this. They're asking for the letter, and they're frequently very complimentary after they receive them about how it's been of assistance to them. This is an example of a letter he provided. You can see it's very similar to a CPC, so there's a clinical history paragraph. Here are the findings that are related to the disease process that we were discussing. Well, in this case, we actually found something that was unknown. And here's how they explained it. And here they add the information. In this case, the woman had colon cancer, and that this may be something that runs in your family, and they recommend that you follow up. So in conclusion, the points I'd like to make is the autopsy today is still an important procedure, despite our high-tech medical environment. It still detects significant missed findings in patients. It does not lead to lawsuits, provides insight into the evolution of disease and medical care, that families desire and deserve answers, that the virtual autopsy is not yet ready for prime time in the hospital, but we can and should use and develop some of these tools to help enhance the autopsies that we are doing. We need to conduct our autopsies more intelligently. One size does not fit all. We need to focus our resources to answer questions from families and clinicians. We need to apply the tools we're using every day in our pathology practice to the autopsy. We need to complete our exams and provide our results in a timely manner. The autopsy report needs to be updated, written for the reader of today, with an emphasis on the CPC and direct answers to the clinician's questions. The data needs to be structured so this information is easily searchable and retrievable for a variety of uses. We need to focus the autopsy back to the family, who has graciously provided us the permission to perform this examination. We need to remember this is all about the family. And it would be great if we could all have deceit and fair offices, but even a well-written letter to the family explaining the findings could go a very long way. And finally, as pathologists, we need to recommit ourselves to the autopsy as more than an important, a vital part of the practice of medicine. And as pathologists, we need to lobby for the resources necessary to accomplish these goals. So at this point, I thank you, and we'll throw this open to questions and see where we are with that. So let me pull the questions out. Here we go. The first question is, why was the 20% minimum autopsy rate in 1971 eliminated? Did organized pathology lobby for or against this change? I do not know whether pathology did, what pathology's involvement was in lobbying for the change. This was a change by the what is it called now? The licensed group that accredits healthcare organizations. They had eliminated it back in 1971. I do not know why they made that decision. That was the only question I saw posted. Does anybody else have any questions they would like to ask?
No other questions have come in at this time, but we can wait another minute to see if any are submitted.
Okay, we have another question about what is the increased cost by Autopsy. Interestingly enough, they are not really providing a lot of good information on how much this is costing. I have trouble believing that the cost of performing a Autopsy is not going to be significantly higher than that of performing an autopsy itself. Especially with the use of MRI, which is a very expensive piece of equipment. We're looking at a significant cost, as well as the cost of the time of radiologists to be able to interpret these scans. Now the question becomes, are pathologists going to become trained to a point where they can evaluate these scans, just as we, especially in the forensic world, regularly use standard radiology and make evaluations of radiology ourselves. So the answer is, while there isn't a number yet assigned to this increased cost, there is a significant increased cost to performing Autopsy by the nature of the equipment that's being used.
And we are at the top of the hour. I will pass on any unanswered questions to Dr. Levy.